you can get started with introductions.
Okay, set up my screen sharing here. All right, welcome everyone. I'm Dr. Dustin Long, and I'll be moderating this session today. I'm a critical care anesthesiologist at the University of Washington and perform research on the microbiome, bacterial evolution, and antimicrobial resistant infection. The title of today's webinar is Perioperative Infection, New Risks in the Emerging Science of Prevention. I wanted to thank you for joining and preface this session by acknowledging the IARS for supporting the discussion of infection prevention in this forum and provide some introductory context for the significance of these issues. So first off, why focus on healthcare-associated infection as anesthesiologists? In our field, we've traditionally focused heavily on the prevention of major pulmonary and cardiovascular complications of surgery, but with improved techniques and monitoring technologies, we've become better at preventing these types of events. These are recent data from NSQIP, which show that this is really just one slice of the pie. And if we want to expand our impact on perioperative quality and safety, we should consider broadening that scope to look at infection. Postoperative infection is now the most common complication of modern surgery, as captured by NSQIP. It's also the #1 cause of postoperative readmission at our hospitals. It's a major driver of excess healthcare cost. And in the US, measures of infection are heavily weighted in national hospital quality metrics, impacting reimbursement and public benchmarking, things like CMS and Leapfrog. You may not know it, but the ASA score that you assign is one of the most influential factors used to adjust risk in these models for your hospital. In contrast to many other quality measures, healthcare-associated and postoperative infections are not getting better over time, and by some measures, they're even getting worse. And so today we're hosting several experts to discuss these issues within the context of anesthesiology and critical care medicine. We'll cover new considerations related to airborne transmission and lessons learned from COVID-19, discuss the use of new technologies for tracking transmission of more conventional pathogens within our ORs and ICUs, the way that new understandings of the patient microbiome and antimicrobial resistance impact future approaches to these problems, and finally, strategies for effectively implementing evidence-based changes in infection prevention within the real complex health systems where we all work. With that, I'd like to invite Dr. Bowdle to start us off. Dr. Bowdle is a professor of anesthesiology and pharmaceutics and the Laura Cheney Professor of Anesthesia Patient Safety at the University of Washington here in Seattle. He's a cardiothoracic anesthesia subspecialist whose contributions to patient safety include the development of medical devices, computerized checklists, collaborations with the APSF and with the Society of Healthcare Epidemiology of America, including the development of the first SHEA expert guidelines for infection prevention in the operating room anesthesia workspace. Please welcome Dr. Bowdle.
Thanks, Dustin. Let me just share my screen here. So I'm going to talk today about protecting patients and healthcare workers from aerosol transmissible diseases. I think. And I have nothing to declare, no conflicts. So the droplet dogma. The traditional dogma is that transmissible respiratory diseases are spread primarily in large respiratory particles called droplets, produced in large quantities during coughing or sneezing. These particles fall to the ground after traveling only a short distance, leading to the notion that 6 feet of separation from the infectious source provides protection from infection. Infection is transmitted according to this dogma, when the droplets fall directly on the mucosa of the oropharynx or conjunctiva. Surgical masks are thought to prevent infection by covering the nose and mouth. Unfortunately, the reality is very different. During normal breathing, respiratory particles spanning a range of sizes are emitted, and the smaller particles can remain suspended in the air for prolonged periods. They can travel long distances and can be inhaled deeply into the lungs. These particles are known as aerosols and are often referred to as being airborne. The traditional dogma calls out only a few diseases for airborne transmission, such as tuberculosis and measles. But the reality is that many pathogens can be aerosolized. The list of aerosol transmissible diseases is actually quite long and includes COVID-19, influenza, respiratory syncytial virus, adenovirus, just to name a few. And the pathogens can be bacteria as well as viruses. For example, an outbreak of Legionella in France was attributed to a source that was up to 6 or 7 kilometers away from some of the victims. Influenza, which of course is one of the most important diseases with pandemic potential, is often described as being spread primarily by droplets, but in fact it's airborne. And this has been known since the 1950s, as shown by this old experiment in which UV irradiation of air in a hospital ward was shown to prevent the spread of influenza. It's important to realize that bacteria as well as viruses can be spread by aerosols. For example, healthcare workers whose respiratory tracts are colonized with bacterial pathogens can spread them to patients, particularly when they have viral illnesses that increase respiratory secretions. This past spring, at a meeting of the Society of Healthcare Epidemiology of America, I actually heard a case presentation about a cardiac surgeon colonized with MRSA who also suffered from allergic rhinitis and caused a major outbreak of sternal wound infections in her patients. Recognition of the importance of aerosol transmission has led to reevaluation of methods of respiratory protection. A key realization is that surgical masks do not provide very much protection from aerosols because they don't fit tightly enough to the face and they don't filter well enough. Surgical masks are useful as part of so-called standard precautions for splash protection against blood and body fluids. While they are undoubtedly better than no face covering at all, they are far inferior to respirators for providing protection against aerosol transmission. The laboratory evidence demonstrating the limited efficacy of surgical masks, if you look at it carefully, is actually irrefutable. Respirators, such as N95 or FFP2 respirators, fit tightly against the face and have highly effective filtering material. When fit properly, they provide substantial protection from aerosol transmission. And again, the laboratory evidence for the superior effectiveness of respirators is extensive in comparison to surgical masks and is really at this point irrefutable. While much attention has been focused on the role of masks and respirators for prevention of aerosol transmission, perhaps not enough attention has been paid to ventilation and air purification. By decreasing the amount of respiratory particles in an indoor space, ventilation and air purification can significantly decrease the risks of aerosol transmission, improving the efficacy of masks and respirators, or even making them unnecessary. The standards for operating room air exchange and filtering are relatively high, but many hospital spaces are subject to standards that are not even as high as those for commercial buildings. Thus, many spaces in hospitals are not well protected by ventilation. The use of portable HEPA air purifiers, as illustrated in the slide, is a useful measure to add additional protection for inadequately ventilated spaces. An alternative to filtering facepiece respirators, such as N95 respirators, are loose-fitting PAPRs, shown on the left. PAPRs provide even better protection than N95s for the wearer. However, loose-fitting PAPRs have a major disadvantage, which is that the exhaled air is unfiltered. Thus, they provide no source control. This is fine if only the patients are infected and none of the healthcare workers. But if there is community spread that affects healthcare workers as well as patients, then source control is important for the healthcare workers as well. A better alternative in this setting may be a tight-fitting PAPR with filtration of the exhaled air, as shown in the example on the right. Another alternative to filtering facepiece respirators, such as N95, are elastomeric respirators. These are cleanable and reusable, and their filters can last for very long periods of time. Thus, they are ideal for pandemic and surge use when N95 respirators may be in short supply. Elastomeric respirators for healthcare should not have exhalation valves. Both inspired and expired air should be filtered. In response to the public's need for respiratory protection during the COVID pandemic, a new class of face covering was defined by ASTM in the United States and by other standards, other organizations in the EU and elsewhere. The intention was not to replace respirators, but to establish standards for the performance of face coverings that were more effective than cloth face coverings or surgical masks, but less effective than respirators. These are known in the ASTM jargon as, quote, barrier face coverings, unquote. They are not intended for use in healthcare settings. And the key thing to understand about ASTM barrier face coverings is that they are really not a substitute for respirators. Well, when do we need respirators? Given that aerosol transmission is common and respirators provide so much better protection, when should we wear them? Well, one possible answer is always. Another possible answer is when community transmission is high. However, what does that really mean? What is high, and how do we know that it's high? Currently, our tracking of COVID-19 is based almost entirely on wastewater sampling. An intriguing possibility for the future is rapid, inexpensive, near real-time air sampling inside a building to test for SARS-CoV-2 or other pathogens. And this is illustrated in the paper in this slide and may actually be a possibility in the near future. Is there a time in the future when we won't ever need respirators, when this will all be over? The answer to this is no. We now realize that aerosol transmission is so common, and there are so many pathogens that can be transmitted in aerosols, and so many pandemic threats, that it is highly likely that respirators are going to be part of our lives for the foreseeable future. However, improved ventilation and air purification could go a long way towards minimizing the need for respirators. A common question about respirators concerns whether they are for single patient use or how long they can be used. It turns out that when respiratory particles are trapped in the filter of an N95 or similar respirator, they get stuck there and they don't come out. Therefore, N95 respirators can be used until they no longer fit effectively. And given that there is virtually unlimited availability currently of N95 respirators, my personal practice is to wear a single N95 respirator for an entire working day. But in a crisis situation with limited supply, N95 respirators really can be reused until they no longer fit well. In my view, the operating room is a place where N95 respirators should be the face covering of choice. There are several reasons for this. We need to protect each other and our patients from aerosol transmission of diseases like COVID and influenza, but we also need to protect our patients' surgical wounds from aerosolized bacteria from our own airways. One of the defining aspects of operating rooms is that people spend long periods of time in very, very close proximity, which is a setup for aerosol transmission. In addition, there is often a need to protect workers from surgical smoke produced by cautery and laser, which has been recognized for decades as a significant health hazard. While operating rooms have very good ventilation in most cases, the ventilation is not so good as to eliminate the risk of aerosol transmission. And this was illustrated by a very well-documented case shown on the slide of infection of a transplant surgeon in the operating room wearing a surgical mask, infected with COVID from a donor lung that was not realized to be infected at the time. In conclusion, the droplet dogma is dead. Aerosol diseases rule. Surgical masks are for splash protection and do not provide very much protection from aerosol transmission. By contrast, respirators such as N95 provide very good protection from aerosol transmission. Ventilation and air purification are important and need to be improved in hospitals and other buildings. Portable HEPA air purifiers are a valuable tool to improve indoor air when major infrastructure improvements are not possible. We now recognize that aerosol transmission is ubiquitous. Just as there is no return from blood-borne precautions after the AIDS epidemic, there is no return to an era of no masks or surgical masks, as was the case before COVID-19. As a famous epidemiologist has said, like 2019, never again.
Thank you, Dr. Bowdle. We will now transition to Dr. Loftus for an update on more conventional classes of healthcare-associated infection and the emerging science of how these pathogens spread within our perioperative environments. Dr. Randy Loftus is an anesthesiologist and intensivist at the Mayo Clinic in Rochester. His academic focus involves prevention of perioperative bacterial transmission and associated infection development, and he has truly been a pioneer in this field. Welcome, Dr. Loftus.
Thank you, Dr. Long. I'm going to go ahead and share my screen. All right. So the focus of my talk is on perioperative infection development, how it develops, and how we as anesthesia providers can control it. There's a lot of evidence in this area. The talk is going to be brief, approximately 10 minutes, and we'll have questions at the end. Here are my disclosures listed here. So there are three major goals for this brief talk that I have here, which is one, I'd like to highlight the significance again. I know Dr. Long already mentioned it, but we'll briefly highlight the significance of surgical site infections. And we're going to quickly move into characterizing the importance of bacterial movement, how movement of bacterial pathogens in the anesthesia workspace can result in surgical site infections. And then finally, what we as anesthesia providers can do to reduce that movement and ultimately reduce surgical site infections. And I will share with you some solidified evidence that represents what is now a new standard of care. Because if we can do these things, we have an opportunity to reduce surgical site infections by 80%. And there is a great need to disseminate this information among hospitals in the United States. So surgical site infections are a problem, as Dr. Long mentioned earlier. They are persistent. They are the #1 surgical complication. It's a problem that's not going away. It does increase patient mortality by about 2-fold. These infections do increase the risk of patients ending up in the intensive care unit. They do result in prolonged hospital stay of approximately 7 to 11 days in duration. And they are the #1 reason for unplanned readmissions, approximately 20%. And all of these things do impact the cost of care. And if you look at the increased cost, the average increase in cost for surgical site infections across the board, it's approximately $25,000 per infection. But of course, there are infections that increase costs more than others. So for example, a mediastinal infection can cost upwards of $100,000 versus a urinary tract infection, which can cost around $800 to $1,000. So there is variability, but on average, you're looking at an increase in cost by about $25,000. Now, a big part of the problem for the development of surgical site infections is bacterial movement or transmission. And what is shown here is a spaghetti diagram that depicts provider, environmental, and patient interactions in the operating room. So one of our research assistants sat in a room and mapped out provider movement during an elective surgical case of 3 hours in duration. Now, each line that you see here represents one provider patient environmental interaction where a provider was going between those different areas. The difference in colors represents difference in providers. So yellow represents anesthesia providers, purple represents surgeons, and the black lines represent the circulating nurses. What you can see, hopefully, is that there's a difference in task density. And my hope is that you can see that the yellow lines are much denser than the rest, because we as anesthesia providers have a very high task density. And what we know is that as task density increases, our ability to adhere to basic preventive measures like washing our hands or cleaning the environment is reduced dramatically. And when we fail to adhere to these basic preventive measures, the risk of moving bacteria from one location to another, or bacterial transmission, increases. And all of these different reservoirs are intricately related by various mechanisms, touching the environment, touching the patient, going back and forth. But also, as Dr. Bowdle mentioned, there is the concept of aerosolization, where you have all of these reservoirs with these pathogens that can become aerosolized and spread from one area to another as well. Now, the risk of surgical site infection is impacted by bacterial movement. So in one study that involved 512 patient pairs, so a patient pair would be the first and second case of the day in an operating room where patients are monitored sequentially, so that you can map movement from within a patient and from one patient to another that would correlate with vertical transmission on the hospital floor or horizontal transmission. So in this model, in this study that involved 512 of these pairs, 2% of patients developed infections if there was no movement of Staph aureus. So Staph aureus stayed where it started. It didn't go from the environment to the patient or from the patient to the provider hands. It stayed where it originated. In those cases, 2% of patients went on to develop a surgical site infection within 90 days. If there was movement, however, that was detected of Staph aureus, so wherever Staph aureus started, it ended up somewhere else. So a practical example would be it started on the anesthesia provider's hand and it ended up on the patient's axilla. If you could detect movement, then the risk of a surgical site infection was 11%. And then finally, if you could detect movement of organisms that were resistant to the prophylactic antibiotic that was employed for the surgical procedure, 18% of those patients went on to develop a surgical site infection within 90 days. So to think about this another way, anesthesia providers movement of bacteria in the anesthesia workspace accounts for half of surgical site infections that develop. Because if you look at the 512 pairs, the overall percentage of patients that went on to develop an infection was 4%. If there was no transmission, no movement of Staph aureus, 2% of patients were infected. If there was transmission of Staph aureus, 2% of patients went on to be infected. So what that means is that we as anesthesia providers in that workspace have an opportunity to prevent half of surgical site infections. Now, the way that we can do this is by adhering to 4 basic pillars of infection control. And those include patient decolonization, better hand hygiene, better vascular care, including peripheral IVs, central lines and arterial lines, and better cleaning and organization of our environmental workspace. All of these measures are behavioral. And what that means is that they're prone to failure. So we need to monitor all of these different infection control approaches for fidelity or effectiveness over time so that we can improve or optimize these efforts. This concept was tested in a cluster randomized trial at the University of Iowa in 2019. This trial involved approximately 40% of patients at the University of Iowa. 40% of surgeons at the University of Iowa and their patients. And what it tested was the impact of implementation and optimization of these 4 pillars: improved hand hygiene, improved patient decolonization, improved environmental cleaning, and improved vascular care with feedback optimization. And this feedback optimization involved mapping how Staph aureus moved, identifying improvement targets, and communicating those improvement targets to the healthcare providers so that they could address gaps in patient care. That approach was compared to usual care, and patients were followed for the primary outcome of Staph aureus transmission and the secondary outcome of 90-day surgical site infections. And what the authors found in this study was that with optimization of these 4 basic infection control measures, Staph aureus transmission was nearly eliminated. And in turn, surgical site infections were reduced by over 80%. So this study provided very promising evidence that if we can just improve across the board these basic measures, then we have an opportunity to have a great impact on the #1 surgical complication today. Following this study, Dr. Wall at Georgetown, MedStar Georgetown, implemented an effectiveness study. So instead of looking at the efficacy of optimization of these 4 pillars, Dr. Wall looked at effectiveness, which means how well does implementation and optimization of these measures work for the overall surgical population outside of the confines of a randomized trial. If a hospital system implements for all comers these interventions, what impact on Staph aureus transmission and surgical site infections does it have? And what Dr. Wall found is that, similar to the randomized trial, that with optimization of these 4 pillars, Staph aureus transmission was substantially reduced, and so too were surgical site infections. This study validated the results of the randomized trial and again provided evidence for effectiveness. So based on this information, we now know that we have established efficacy and effectiveness for implementation and optimization of 4 basic infection control measures in the anesthesia workspace that can reduce bacterial transmission or movement. And when that movement is reduced, so too are surgical site infections, #1 surgical site complication. Shown here is the impact that optimization of these 4 pillars had on the bacteria. So on the y-axis, you see the count of pathogens. the colors represent different reservoir contributions. So for example, red would be the contribution of vascular devices to the number of pathogens brought into the anesthesia work area. And then the x-axis represents time. And the gap between is the acute COVID-19 period where all monitoring had to cease. But what you can see is that as Dr. Wall and his group were implementing and optimizing these 4 basic pillars, the reservoir contributions changed. You can see that the red was nearly eliminated. And looking at the y-axis, you can see that the count of pathogens was substantially reduced. So logically then, if bacteria are causing surgical site infections and movement of those bacteria is associated with increased risk of infection development, if you eliminate the presence of the bacteria in that workspace, that infection should fall. And as expected, they did. So in conclusion, surgical site infections are a significant and persistent issue. Bacterial movement or transmission in the anesthesia workspace accounts for approximately half of surgical site infections. This movement is preventable by anesthesia providers by simply implementing 4 basic pillars of infection control: patient decolonization, environmental cleaning, hand hygiene, and vascular care. And this is especially important to prevent movement of antibiotic-resistant pathogens. If anesthesia providers successfully implement these interventions and optimize them, we have the opportunity as leaders in patient safety to reduce surgical site infections by over 80%. Thus, widespread implementation of this new standard of care is indicated. And as Dr. Brown will talk about here shortly, this is the focus of our current research program that involves an R01 grant titled The Basic. And that concludes my talk. Thank you.
Okay. So I'm Jeremiah Brown. So I'm the director of the Dartmouth Center for Implementation Science and professors of epidemiology, biomedical data sciences, and health policy. I'm also the chair of the Science of Implementation in Health and Healthcare Studies section at the NIH, and no financial relationships to disclose. So implementation science is a multidisciplinary scientific approach using qualitative and quantitative methods to uptake evidence-based interventions into routine use. And implementation science can really just be generally referred to as moving evidence into action or the innovation into dissemination and doing science in the wild. And a recent undergraduate student actually referred to the field as summarizing as taking the no to the do. And the implementation science really needs to be considered in all areas of the translational spectrum, from the pre-intervention phase in efficacy studies, effectiveness studies, and then implementation studies, really focusing on what makes a program work in practical settings. So implementation science also evaluates multi-level factors and processes that influence implementation of a certain program or intervention. It develops and tests strategies to overcome barriers to adoption, integration, and sustainability, and also brings evidence-based practice to scale and addresses their underuse. The field is really driven by multidisciplinary influences, including intervention and effectiveness and process research, healthcare and behavioral economics, medical anthropology, organization and management and marketing, social psychology, adult education and learning, and improvement sciences. And we return back to the traditional translational spectrum. The implementation research really lives in and after the effectiveness studies, focusing on how to make a program work, and includes 4 major steps of exploration, preparation, implementation, and also looks at sustainment of an intervention. And when you think about efficacy and effectiveness as we're moving along that translational spectrum, the efficacy or your classic randomized trials, many of the patients look very similar. So that you have very tight and rigorous inclusion and exclusion criteria. And when you move to the real world setting and looking for effectiveness of an intervention, like Dr. Loftus was talking about, moving from the Iowa setting of the efficacy trial to more of an effectiveness study at Georgetown, people start to look more different because you're looking at all comers and circumstances and the context of the practice might be different. And so that's sort of how we think about comparing sort of efficacy and effectiveness. And we move along to sort of consider what's different about when we look at effectiveness outcomes versus implementation outcomes. When we're talking about effectiveness on the left, we're focusing on the intervention and evaluating the health outcomes, and that becomes the priority of what you're focusing on. When you're looking at implementation outcomes, you're focusing on the systems to support the adoption and delivery and even the fidelity to that intervention. And you're evaluating the quality, quantity, and speed of the delivery of that intervention. This is an excellent example of sort of where implementation research and research approaches really fit into the translational spectrum. And if you're ready to leverage implementation methods. And this was developed by Dr. Megan Lanefall at UPenn. And so you start on the left of the subway diagram where you have your practice or thing of interest that you want to test. And you have to determine, well, do you have efficacy data on that? If you don't, then you need to do your trials and develop your efficacy research for that certain intervention. If you do, like the trial that Dr. Loftus was sharing about for BASIC that was done at Iowa, we have established efficacy data, and then we can move on to focus on effectiveness and also implementation endpoints. Another major unique aspect of the implementation science field is leveraging robust qualitative findings and methods to really focus on the context of the setting. And the field uses a number of different frameworks that helps us understand both facilitators and barriers to the implementation or adoption of the thing that you're trying to work on. One of the classic models that's often used frameworks is considered a consolidated framework for implementation research, or CFR, that is a determinist framework that focuses on identifying the facilitators and barriers of adoption, and also considers both the inner setting of your individual patients or your microsystems. This could be an operating room setting for this instance, and also the outer setting, which could be the hospital or health system that you're focusing on. But it adds additional scientific rigor to the field that you're looking at. So let's take, for example, a case study of the trial that Dr. Loftus was sharing about from Iowa. And this study that was published in JAMA Network Open developed the efficacy data on a multifaceted intervention. And as he shared, it demonstrated over 40% reduction in bacterial transmission, and also resulted in over 80% reduction in 60-day surgical site infections. So we have strong efficacy data that was developed from that trial. And as he went over there, it was a multifaceted intervention that focused on 4 major areas of provider hands, patient-specific interventions, environmental context and points and cleaning, as well as addressing vascular devices. So when we bring this efficacy data into the implementation science space, one thing that we've been doing is trying to leverage the field of implementation science as a vehicle to accelerate the adoption of evidence-based practice interventions. And through doing that, we're leveraging multiple sort of hybrid study designs. So in the basic study design, we randomized 12 sites in a 2x2 factorial design where we're focusing on effectiveness outcomes as well as implementation outcomes. And the main aims of the study were on escape transmission and surgical site infections, looking at sustainability as well as cost effectiveness. And the 12 sites are here presented across the map of the US that we're working on the trial. And this is where both the efficacy data as well as our implementation trial fit back into the subway line. And I'll leave it there, and we'll enter into, I think, question and answer time. And also, if you're interested in implementation science training, we're doing a lot through the center, and we're also in the process of launching a new online master's. So thank you.
Thank you, Dr. Brown. I'm working on reestablishing screen sharing here. All right, does this come through? Looks like yes. To complement the information on perioperative transmission shared by Dr. Loftus and Dr. Brown, I'll be sharing a brief overview on the roles of the patient microbiome and antimicrobial resistance, which provides some alternative ways for us to conceptualize and address some of these problems. I have no disclosures. So the first theme that I wanted to introduce is this conceptual model in which most healthcare-associated infections arise from procedure-associated perturbations of the patient microbiome. The traditional mindset that we have is that the patient comes to the hospital uninfected and that contact with these new nosocomial pathogens is the principal driver of infection. And from this perspective, these infections are hospital acquired specifically because they result from acquisition of these exogenous pathogens from the hospital environment. But a complementary and emerging view of infection places the patient rather than the hospital at the center of this conceptual model, where most infections arise from the bacteria colonizing the patient prior to admission. In this sort of BYO bacteria model, infections are healthcare associated because the procedures and the stresses that induce them uniquely occur within the hospital environment. This often involves disrupting normal barriers that anatomically compartmentalize the human biome and control it. For example, a surgery is performed and then bone or other tissue is exposed to the skin microbiome, or the abdominal wall is exposed to the intestinal microbiome and we develop a surgical site infection. Or we place a plastic conduit between the skin of the neck or the groin into the bloodstream, from the urethra into the bladder, or the oral cavity into the airways, and this leads to central line-associated bloodstream infections, catheter-associated UTIs, or ventilator-associated pneumonias. Alternatively, this seeding can happen hematogenously through poor IV system practices, as was mentioned, especially in surgical procedures involving implants. And then finally, the normal colonizing bacteria can simply flip a genetic switch from modes of stable colonization in our bodies to states of infection as a result of fairly common perioperative stresses. Obviously, both exogenous and endogenous bacteria are important, but there's a growing amount of information about this interplay that gives us kind of a relative sense of these contributions of the original sources of these bacteria. The numbers look something like this, about a 20-80 split in many studies, but I'm putting a big prominent asterisk up here because these paradigms are not mutually exclusive and there is a lot of interplay. For example, bacteria often kind of catch a ride from sites of colonization through the healthcare environment, through all of these points of contact and reservoirs to their ultimate sites of infection on the hands of providers or other surfaces. But I still think this distinction has some practical implications that we'll talk about, and the data are pretty compelling. So for example, this includes C. diff infection, as was shown in a very cool paper in Nature Medicine from a couple of months ago, bloodstream infection, ventilator-associated pneumonia, and of course, surgical site infection, all of these showing the predominant role of routinely colonizing bacteria of patient origin in the pathogenesis of healthcare-associated infection. Now let's hold on to that concept for just a moment as we transition to another one related to the changing landscape of antimicrobial resistance. Layered on top of all of this transmission is the fact that antimicrobial resistance, not just in our hospitals, but actually in our communities, is a threat to the ongoing efficacy of surgical prophylaxis. And this is related to some of the Q&As I see coming up in the chat from earlier. This also has the potential to really exacerbate disparities in health outcomes, both in the US and internationally. There's some great data behind that. Just for perspective, the addition of routine surgical prophylaxis back in the 1950s and 1960s really drastically cut SSI rates in half or more across a wide range of surgical procedures. But now, half a century later, up to half of these infections in the US are resistant to the prophylaxis that's recommended for that procedure. This might explain some of our lack of progress. In some of our own research here, we're also seeing a signal for emerging resistance to chlorhexidine skin prep. This is only anticipated to get worse with time. Over the following decades, this is likely to contribute to tens of thousands of additional SSIs. More bad news, as Dr. Loftus mentioned, these resistant strains are also more likely to be the hypertransmissible ones that drive the spread of infection between patients in perioperative environments, as was seen by this recent work from two of our panelists. And tragically, the burden of antimicrobial resistance is disproportionately borne by populations of lower socioeconomic status. Now, this all sounds very discouraging, and these are formidable problems, but I think there's actually hope that some of this awareness can empower us by informing new infection prevention strategies. For example, if we know that most SSIs arise from bacteria colonizing the patient prior to surgery, that colonization varies dramatically from person to person, and that appropriate prophylaxis targeting those bacteria is effective in reducing SSI, but that half are resistant to the traditionally recommended prophylaxis, and that resistance is detectable before the time of surgery. Why can't we use that prior knowledge to target infection in a more individualized fashion? Maybe we need to evolve from this one-size-fits-all approach to something that's more individualized, informed by preoperative assessment of the patient microbiome or by predictive models of resistance. Maybe we can also stabilize the patient microbiome prior to surgery or early in the course of critical illness instead of neutralizing it or provoking it to prevent the transition from colonization to infection. Just at a practical level, I wanted to mention a few things that we're doing here at UW to try to make some gains in this from a hands-on standpoint. We're shifting a lot of the responsibility for perioperative infection prevention kind of strategically from infection control to surgery and anesthesiology. It's sort of a joint ownership model, and this has been very effective so far. We are doubling down on our MRSA screening. We're changing our approach to decolonization and patient hygiene across all 4 of our major hospitals, which is a large undertaking. We're focusing on the burden of resistant infection in underserved populations, like where I work at Harborview, and we're doing deep preoperative microbiome sequencing in major spine surgery, which has really confirmed a lot of this overall framework. Finally, we're also working with IMPOG to have microbiology and AMR data added so that we can all do research and quality improvement in this area. And to those joining today from IMPOG sites who have an interest, I would really like to talk with you about this. With that, I will close, and we have about 10 minutes left for Q&A. And if all of the panelists could join back and turn on their video, I will stop my sharing. So perhaps we can approach some of these questions as discussion points and then follow up in Doc Matter with a link that will be shared with those that we don't get to, and kind of move in chronological order through the series of presentations. I see a question for Dr. Bowdle. How much aerosol is actually generated during a routine and uneventful extubation in the OR? Is this truly an AGP of concern?
I think that's a great question. There, in the past and during much of the COVID pandemic, there has been quite a lot of emphasis on so-called aerosol generating procedures and with airway management, intubation and extubation and so on often being mentioned. And as I'm sure many of us have experienced, this manifested itself as taking special precautions in the operating room when anesthetizing patients with aerosol transmissible diseases like COVID. I think that that most of the data now suggests that in fact, ordinary airway management probably results in no more risk for aerosol transmission than does simply breathing. And this relates, I think, to this argument over the relative roles of droplets and aerosols. So the idea that there are aerosol generating procedures is really, in a way, part of the droplet dogma. It's the dogma that doesn't recognize that a tremendous amount of aerosolization occurs simply with ordinary breathing. And this then focuses on coughing and sneezing and things that might generate droplets. So we have actually long thought that the role of so-called aerosol generating procedures was really very exaggerated. And in fact, most recent data support that. And so I don't really consider airway management in anesthesia to be any more hazardous in terms of aerosol transmission than simply breathing in the same space with someone who's infected.
Great. And then a series of questions to Dr. Loftus and Dr. Brown, potentially informed by some of your work on the BASIC trial. Could you speak to what you've learned and what you advise as far as optimal approaches to preoperative decolonization, and then also speak to if you have thoughts about kind of intermittent screening and decolonization of healthcare providers?
Sure, I can answer I'll answer those. So there are a number of ways that anesthesia providers can help their institutions and their own practice to more effectively decolonize patients. There is the evidence for patient decolonization is firmly established within the literature, dating back to 2000, when Bowdle and his group did a randomized control trial where patients admitted to the surgical ward and then underwent surgery. So they were admitted before surgery and they were exposed to these pathogens. They were randomized to receive a nasal mupirocin antibiotic as well as chlorhexidine wipes, which carries a broad spectrum activity, antimicrobial activity. They received those agents for 5 days. So the mupirocin was twice daily and the chlorhexidine wipes twice daily. And then they follow patients for development of surgical site infections. And what they found in that study, which was published in the New England Journal of Medicine, was that, yes, surgical site infections were substantially reduced with an absolute risk reduction of 7%, which is good and important. It's one part of the complex interplay. It's not 80%, as we've shown with the multifaceted approach. But yes, patients play a role. It was around 7%. Then other studies asked the question, with increasing antibiotic resistance, do we need to be using nasal mupirocin, which is a topical antibiotic? So a number of randomized trials have looked at using povidone iodine, elemental in nature, and what is the impact of iodine, which can also effectively eradicate Staph aureus, on surgical site infection development. And they found that there was really no difference in the efficacy of povidone iodine versus nasal mupirocin. So you can address patient decolonization by using nasomepiricin, by using povidone iodine. Both of those should be combined with chlorhexidine wipes that are 4% gluconate to address the patient's skin, which can harbor organisms as well, especially sites that are tightly correlated with infection development, such as the axilla and the groin. Does that answer the question?
I think so. And then could you speak to any perspective on kind of the flip side of decolonization for providers who are in these shared environments?
Sure, I think that we can start to move towards provider decolonization, especially when you think about what Dr. Bowdle presented with the fact that we wear these masks, but they're really not effective in preventing aerosolization of pathogens, including bacterial organisms. And we know that providers, just like patients, are colonized and do become colonized with these pathogens during the process of patient care. But I think first and foremost, we need to establish what is grounded in science, which is effective implementation of what is both effective and efficacious. And that is these standardized approaches to patient decolonization. And some might say anesthesia providers are busy. We have little time. How can we perhaps get involved in that process? Well, the answer doesn't necessarily mean that you as a provider need to decolonize your patient, although I think you should. What it means is that you as a historical and current leader in patient safety belonging to that group can work with your hospitals to form perioperative infection control teams that include circulating nurses, surgical techs, surgeons, CRNAs, anesthesiologists, anesthesia techs, all of these people, and use a multidisciplinary approach to achieve buy-in at your hospital and achieve widespread implementation of what we know can address a reduction in patient risk by improved decolonization. Once you've established that, and once we've established widespread adoption of what we know works, I think the next step then is to think about what else can we do. And one of those might be to address provider decolonization, but I don't think we're there yet because we haven't addressed patient decolonization yet as a group. So I would start there. And then once we've done that as a group, then we can think about moving on to the next phase. Because as Dr. Brown pointed out, you need to establish efficacy first, then effectiveness, and neither of those have been established for provider decolonization. So we're just not ready for that yet.
Wonderful. I think that really resonates with a lot of our experience here, both in terms of decolonization and then also taking a role as anesthesiologists in hospital administration as it relates to perioperative infection prevention. Administration has been very supportive of the role of anesthesiologists in that domain, and it's been a very positive experience, at least at Harborview Medical Center. We are at the hour, and so we should wrap up. I see that there are several questions still unanswered in the Q&A, and I have recorded those, and we will address those offline in this Doc Matter portal here, and I'll make sure that each of those gets routed to the right speaker and addressed. There are some great questions in there that I think would be of interest to the group. So thank you, panelists, thank you, attendees, and thank you, IARS, for hosting this session today.